Good evening, friends. In this lecture, we will be discussing about the infertility, mainly the male infertility part and its treatment. So, what is infertility? If a female is unable to conceive even after 1 year of sexual intercourse, if her age is less than 35 years, then this is infertility, and if the age is more, that is more than 35 years, then this duration is 6 months. So, within 1 year, 85% of the females usually conceives, 75% conceives by 6 months, and 50% female will be pregnant at 3 months. Infertility is very common and it affects 10 to 15% of the reproductive aged couples. Causes includes the male factors, the female factors, unexplained fertility, and the common factors constituting both male and female. And the incidence of female factors is around 17 to 28%. Both male and female factors is about 8 to 39%. Female factors 33 to 40%. Unexplained infertility in 8 to 28% of the patients. And in female infertility, most common cause is ovulatory dysfunction, which is around 21 to 36%. Tubal and peritoneal factors 16 to 28%. Miscellaneous causes 9 to 12%. Now coming to our main important part, that is male factor infertility. So whenever we are evaluating a patient of infertility, we have to evaluate both male and female partners simultaneously. A male factor is solely responsible in about 20% of the infertile couples, and in total it contributes around 30 to 40%. So the incidence is around 20% in case of male factor. Given the high prevalence of male factor in infertile heterosexual couples, a basic medical history and evaluation is very important, that includes the reproductive history and semen analysis. So the overall goal is to evaluate the male patient in identifying the conditions that may affect the management or health of the patient or their offspring. Any abnormality noted either in the male history or the semen analysis, it warrants a special trained person to evaluate, maybe a reproductive urologist or reproductive endocrinologist, for complete evaluation of the male patient. So in couples with failed ART cycles or recurrent pregnancy losses, what is recurrent pregnancy loss? When the loss is more than equal to 2. So the evaluation of male should be considered. So the goal is to identify the potentially correctable conditions, irreversible conditions that are amenable to assisted reproductive technologies using the sperm of the male partner, irreversible conditions, life-threatening conditions, or genetic abnormalities or lifestyle or age factors that can constitute to male infertility. Now coming to the causes of male infertility, the causes can be pre-testicular, testicular, or post-testicular. Pre-testicular causes means that the problem is lying at a higher level, means either there is defect in the hypothalamus or there is coital dysfunction, means the endocrine cause means this is hypogonadotropic hypogonadism, when the hypothalamus is not releasing GnRH or when the pituitary is not releasing LH and FSH, and this is known as hypogonadotropic hypogonadism. Now the coital disorders means either erectile dysfunctions, which could be psychosexual, endocrine, neural or vascular, or ejaculatory failure after genitourinary surgeries, neural or drug related causes. So the coital disorders and the endocrine dysfunction comes under pre-testicular causes. When the problem lies within the testis, this is known as testicular dysfunction. And the causes includes the genetic factors like the Klinefelter syndrome, Y chromosome deletion, immotile cilia syndrome, congenital cryptorchidism, infective orchitis, anti-spermatogenic agents like heat, chemotherapy, drugs, and irradiation. Vascular causes including torsion or either varicocele, immunologic factors, and idiopathic causes. While the post-testicular causes include epididymal hostility, means this is known as epididymal asthenozoospermia, accessory gland infection, immunologic causes including idiopathic causes and post-vasectomy, obstructive causes like epididymal, which could be either congenital or infective, basal, which could be due to cystic fibrosis, and acquired like vasectomy. Now, the etiological factors in male infertility. Men have reported fathered children and into their 90s, but pregnancy rates are decreased with paternal age. So this is seen both with the male partner as well as the female partner, that as the age advances there is reduced chances of pregnancy, mainly after 40 to 45 years or 50 years. Majority of the cases are idiopathic, and the factors which definitively lead to male fertility includes secondary hypogonadism, genetic causes, seminal tract obstruction, oncological disease therapies, and severe sexual dysfunction. Also, plausible causative factors includes congenital urinary abnormalities, acquired testicular damage, and secondary factors like varicocele, leukocytosis, obesity, and uncontrolled chronic diseases. Now, coming to the history, the following list details with the key specific historical factors to elicit that while taking the history we have to ask the patient about the coital frequency and the timing. So the timing is very important. If the person is having sexual intercourse before ovulation and after ovulation has occurred, then the chances of getting conceived is less, obviously. So the frequency of coitus and timing of coitus is important. Any evidence of sexual dysfunction including erectile dysfunction or ejaculation dysfunction is important. What is the duration of infertility? Prior fertility, whether the person is having a live child or prior conception is there. So prior history of infertility is important. Childhood illness or developmental history, like if the child is having a history of mumps in the childhood, then this can lead to mumps orchitis or tuberculosis of the tubercular orchitis. History is very important. Developmental history is very important when the testes have descended into the scrotum. Systemic medical illnesses like diabetes, hypothyroidism, or tuberculosis, or any chronic disease. Previous surgeries, cryptorchidism with or without surgery. Medications used like steroids, testosterone, and allergies are also the causative factor. Sexual history of sexually transmitted infections, gonadal trauma or toxins or supplementation. Occupation and lifestyle history is very important. So there are certain drugs that can cause male infertility. What are these? The first one is these drugs impairs spermatogenesis, means they inhibit the process of formation of a sperm. So these include sulfosalazine, methotrexate, nitrofurantoin, colchicine, and chemotherapeutic agents. So these three drugs are very important. Sulfosalazine is given in the treatment of ulcerative colitis. Methotrexate is given in various cancer states, and nitrofurantoin, which is given in case of urinary tract infection. Colchicine in case of gout, and chemotherapy. So these drugs impairs spermatogenesis. Now there are certain injections which can inhibit the pituitary or can cause negative suppression of the pituitary. What are these? These are the hormones, obviously. So testosterone injections, gonadotropin releasing analogs, they causes pituitary suppression. Anti-androgenic effects with cimetidine and spironolactone. Cimetidine is proton pump inhibitor, while spironolactone is used in blood pressure conditions. Ejaculation failure due to alpha blockers, antidepressants, phenothiazines. Erectile dysfunction by beta blocker, thiazide diuretics, metoclopramide, and drug of misuse like anabolic steroids, cannabis, heroin, and cocaine abuse. So these drugs are very important. These can inhibit the male infertility. Now to evaluate the male, we have to take a proper history, as well as we have to do the physical examination of the male patient. We have to advise certain investigation. One of them is semen analysis. So what is semen analysis? It is the quantitative microscopic evaluation of the sperm parameters, and whenever we are advising a semen analysis, first we have to tell the patient that the male partner should have an abstinence of about 2 to 5 days before semen analysis, and the sample is obtained by masturbation in the laboratory collection room. Semen collected at home should be transported to the lab within 1 hour, as temperature is very important, and any loss of a specimen, particularly the first portion, should be reported as it contains the highest sperm concentration. And if the masturbation into the container is not possible, then condoms especially designed for semen analysis should be used. Now, abnormalities warrants repeat testing, and the repeat testing is advised after 3 months. So therefore, at least 2 semen analysis samples, ideally not 3 months, it's 1 month, ideally obtained at least 1 month apart, and are important to obtain, especially if the first sample is abnormal parameters are having and the further investigation is required. So if the one semen analysis is abnormal, then we have to advise another semen analysis after 1 month apart. At least 2 semen analyses are necessary to make a diagnosis of abnormality, and the evaluation and treatment can improve semen analysis fertility outcome to conceive naturally and potentially lower treatment cost. In addition, 1 to 6% of the men evaluated for infertility have significant undiagnosed medical pathology, including malignancies, even when they are so-called normal semen analysis reports. So currently these parameters have been changed. Earlier we used to follow the WHO 2020 guidelines, but recently WHO 2023 guidelines for semen analysis or the human semen characteristics have been given, in which the semen volume is 1.4 ml. This is considered as normal, or one side lower limit, reference limit is taken. Total sperm number is 39 millions per ejaculate. So in one ejaculation the total sperm number is 39 million, while the sperm concentration is 16 million per ml. So the concentration is taken in per ml, while the sperm number in per ejaculate, so 39 and 16. So the vitality is 54% of the sperm should be live. Progressive motility should be shown by the 30% of the sperms. Total motility means either progressive and non-progressive 42%. Morphologically 4% form should be normal, and semen samples जो है they should be morphologically normal. Now there are certain terminologies: normozoospermia, oligozoospermia, asthenozoospermia, teratozoospermia, oligoasthenoteratozoospermia, azoospermia, aspermia, leukocytospermia, necrozoospermia. What are these? So normozoospermia is normo means normal, means everything is normal. So when all the sperm parameters are normal, this condition is known as normozoospermia. And if oligozoospermia means oligo means less, so if the sperm number is less or reduced, it is known as oligozoospermia. If the level is 5 to 15 million per ml, so the normal is more than 16 million per ml should be normal. But if the level is 5 to 20 million per ml, it is mild to moderate. And if the count is less than 5 million per ml, it is severe oligospermia. Asthenozoospermia means, astheno means motility, so if the motility is less, then this is asthenozoospermia. Terato means shape, so if there is increased abnormal forms of sperms either due to anti-sperm antibodies, postcoital testing, sperm DNA integrity, then this is known as teratozoospermia. Oligoasthenoteratozoospermia means all sperm variables all subnormal. Azoospermia means there is no sperm in the semen. Aspermia means there is no ejaculate. So if there is ejaculation failure, so this is aspermia. This does not mean that sperms are not there. Sperms are not getting ejaculated. So no ejaculate means no semen at all. It is aspermia. And there is, if semen is there but there are no sperm in the semen, then this is azoospermia. If the white cells are increased, then this is known as leukocytospermia, and the level is 1 to 2 million per ml of the semen. And necrozoospermia, if the dead sperms are more, so all sperms are non-viable or non-motile, means the viability should be more than 54%. Viable sperms have intact plasma membrane, hence they do not stain and will swell up in hyposmolar solution. So this characteristic is used to differentiate between viable and non-viable sperms. So if a patient comes to you, what will you do? So first we take the history of the patient and what is the age of the patient. So after 1 year of failure to conceive the female, so here female age is considered, not male age. So if the female age is less than 35 years, then duration is 1 year, and if her age is more than 35 years old, then 6 months of failure is required to make a diagnosis. Now, male and female partners are evaluated simultaneously, including male reproductive history, and if there is history of vasectomy, then re-vasectomy, then canalization can be considered, or counseling re-post vasectomy fertility options are there, we can consider them. And but if there is no history of vasectomy or tubectomy, then at least one abnormal semen analysis or abnormal male reproductive history is considered. So if husband semen analysis is abnormal or the reproductive history is abnormal, then what we do, we completely evaluate the male partner, and based on the finding in the semen analysis, we make a diagnosis. So if the diagnosis is oligospermia, means the sperm count is less, so this means that sperms are not being made. So if sperms are not getting synthesized, this means that the problem might be lying in the spermatogenesis, and spermatogenesis is the work of the hormones like LH, FSH and testosterone. So this warrants the husband hormonal profile, and we order FSH and thyroid hormone. Okay, and further evaluation and management is important, and FSH and testosterone is important here. Now if the count is normal but still male partner is having something abnormal and is not getting conceived, then treatment of abnormal factors or management with ART. Okay, if there is azoospermia means the count is less. So we have to categorize what kind of azoospermia means there is no sperm in the semen. So first we have to categorize the azoospermia based on the FSH and examination. So we order a scrotal USG, and in scrotal USG the cause can be non-obstructive or obstructive. So if there is no obstruction but still sperms are not seen in the semen sample, then we can order genetic testing like karyotyping or Y chromosome microdeletion, and the option for conception can be micro TC or ICSI. But here the chances of conception are very low. And when we check the hormones in this patient with non-obstructive azoospermia, FSH level is very high because sperms are not being made, so there is positive feedback to the pituitary and it releases increased amount of FSH, and testosterone is low, semen volume is normal, and testes are shrunken in size, means small volume testes. But if the cause is obstructive, so here everything is normal but the sperm is not getting released into the semen, so here the hormones will be normal, semen volume is low, and this semen volume can be normal or low based on the site of obstruction. Testicular volume is also normal. So here genetic cystic fibrosis testing for congenital cases of obstruction and sperm retrieval or microsurgical reconstruction can be considered. And if diagnostic and therapeutic biopsy is taken, if FSH and testicular volume is normal and no clinical evidence of obstruction, then we can advise biopsy also. So this is the flow chart that explain how we are going to manage a case of male infertility. So this we have already discussed. Yes. Now when to send the hormonal profile in male. FSH and testosterone are to be sent in the infertile men with impaired libido, erectile dysfunction, oligospermia, azoospermia, testes are smaller in size, and when there is evidence of hormonal abnormality on the physical evaluation. If the hormone is lesser, that is less than 300 nanogram per deciliter, LH and prolactin to be sent for hypogonadotropic hypogonadism and decreased libido. So these are the parameters that can be seen in the hormonal profile of the patients. First one is if the patient is having severely impaired spermatogenesis, means there is oligospermia or azoospermia you can say. So when we check the hormones, because sperms are not being made, so the FSH and LH levels are increased, and this is not acting on the testes, and testosterone is not getting released, so the testosterone level is low. So testosterone is low, LH, FSH are high. So this is known as hypogonadotropic hypergonadism. So this is hypogonadotropic hypergonadism. Second condition is when everything is normal but there is some obstruction either due to cystic fibrosis or tuberculosis, mumps bronchitis, and everything is normal including LH, FSH and testosterone. Third one is hypogonadotropic hypogonadism, where the problem is lying at the level of pituitary or the hypothalamus, and the hormones are decreased from the center, and hence testosterone level is also low. So this is hypogonadotropic hypogonadism. Now we have seen that if a patient of non-obstructive azoospermia is coming to us and his testicular volume is lesser, there is LH and FSH are on the higher side, while the testosterone is on the lower side, and the patient is presenting with azoospermia, and the cause is non-obstructive azoospermia, and on scleral USG any obstruction has been ruled out. So we have to order the patient karyotyping or the Y chromosome microdeletion analysis if the patient is presenting with primary infertility and azoospermia or oligospermia with increased deficit of testicular atrophy. CFTR mutation means cystic fibrosis mutation carrier testing is done if the patient is also having basal agenesis or idiopathic obstructive azoospermia. For men who harbor this mutation, genetic evaluation of the female partner should be recommended because this is an autosomal recessive condition, and if the father is having the abnormality of this protein, then if female is also homozygous for this or recessive allele is there, then there are chances or either there is heterozygosity, then there are chances that if the baby is born, then through this man and women, baby can inherit the condition. So female partner testing is also recommended if there is CFTR mutation. Now sperm DNA fragmentation, anti-sperm antibody testing is not recommended for couples with recurrent pregnancy loss. Karyotyping of the male and DNA fragmentation index should be calculated. Men with increased round cells on sperm analysis should be distinguished between white blood cells from the germ cells, and pyospermia should be evaluated for infection. So if there is pyospermia or WBCs are more in sperm analysis, then we have to evaluate them for infection and treat them accordingly. Now, what is the treatment of male factor infertility? If there are infections like sexually transmitted infection, we have to advise them antibiotics. If there is thyroid dysfunction, then levothyroxine is recommended. Prolactin X, bromocriptine, cabergoline. Exogenous testosterone is not recommended in the treatment of male subinfertility because negative feedback inhibition at pituitary can result in reduced spermatogenesis. Glutathione, carnitine have no role. Zinc folic acid can improve sperm concentration. Coenzyme Q has been reported to work in case of oligoasthenoteratozoospermia, and clomiphene and testosterone has been shown to be anti-estrogenic in some cases. So this is the treatment part. Now coming to the obstructive parts can be due to varicocele, or this is the testicular cause. Varicocele, what happens in varicocele? That the varicocele leads to increased temperature, and we all know that there is a temperature of around 1 to 2 degrees lesser than the human body temperature to continue spermatogenesis. So in varicocele, what happens? There is abnormal dilatations of the veins within the spermatic cord. So 40% of the male infertile couples have varicocele. The pathophysiological effects of varicocele appear to be mediated by an associated rise in the testicular temperature, and this results in reflux of toxic metabolites from the left adrenal and renal vein or higher reactive oxygen species. While treatment is associated with improved semen parameters in some studies, but it is not clear that it improves fertility also. Treatment is through varicocele repair, either through surgery or through percutaneous embolization is typically considered if the varicocele is palpable and the semen analysis is abnormal, and may allow some couples to use IUI instead of in vitro fertilization to improve the outcomes in settings of oligo and azoospermia. So what we do here, we can do surgery or percutaneous embolization, and IUI can be considered. Complications includes infection, varicocele, persistent recurrence, and the hydrocele. Now what is the specific treatment? So based on the conditions, we will study the treatment part. Coming to azoospermia describes the absence of spermatozoa in the ejaculate. So if there are no sperms in the ejaculate even after the absence of sperms after examination of a centrifuge semen palette, and is found in 1% of all men and up to 15 to 20% of the infertile men. So there are no sperms but the semen is there. It is seen in around 1% of all men. The causes can be pretesticular, testicular, or the post-testicular cause. So the post-testicular cause can be obstructive and non-obstructive, but in some cases this condition can be idiopathic also. Coming to pretesticular azoospermia, already we have discussed that if there is hypogonadotropic hypogonadism like in Kalaman syndrome, Gonadotropin deficiency leads to loss of spermatogenesis, and when we check the LHFSS, they will be low and testosterone is also low. Prolactin levels and pituitary imaging are indicated in these cases. Hormonal treatment here can be given because the hormones are less in amount, so we can give pulsatile GnRH or injection HCG 2000 to 5000 international unit 3 times per week, or exogenic gonadotropins like injection HMG, recombinant FSH can be tried. The best predictors of good response are post-pubertal onset of gonadotropin deficiency and testicular volume more than 8 ml. Now, iatrogenic azoospermia commonly results from medical testosterone use. So, if the person is taking testosterone from outside, then there is inhibition of the spermatogenesis due to hypogonadic environment, and this can lead to iatrogenic azoospermia. Treatment is stopping of the testosterone, so includes discontinuation of the exogenous testosterone, recovery therapy with medication just like clomiphene citrate, HCG, FSH with frequent follow-up semen analysis and endocrine labs. Azoospermia recovers to a median concentration of 6.5 million per ml 4.5 months following cessation of the testosterone use. So, full recovery is more likely who continues or stops testosterone within 1 year, while those who use it for several years were unlikely to recover. Now, what is testicular azoospermia? Testicular azoospermia occurs when the gonadal failure is the hallmark of testicular azoospermia. So, this can be due to radiation, chemotherapy, torsion, varicocele, developmental like testicular maladies and testicular atrophy is often present. Because of low chance of obtaining the sperm, testicular biopsy is generally not recommended with hypergonadotropic hypogonadism. So, biopsy here is not recommended because the cause is either radiation, chemo, torsion, varicocele or developmental, and here we advise to consider donor sperm. Diagnostic while testicular biopsies should not be indicated in settings of normal hormonal testing. So, here the hormones are normal, but the cause is testicular due to gonadal failure, and testosterone is also lesser in amount. If the sperm is present in diagnostic testing, surgically retrieval of spermatozoa for ICSI can be done, and if there is no sperm, then ICSI cannot be tried, but it can restore sperm to ejaculate to permit ICSI and spontaneous pregnancy. Chromosomal abnormalities are seen in 7% of the infertile couples and 5% of the ligospermic, 10 to 15% of the azoospermic men. Sex chromosomal abnormality can be Klinefelter syndrome, which is seen in 2/3 of the patients. Microdeletions can be seen, and therefore screening is very important. Now, next we will discuss the post-testicular azoospermia.